of the other muscles are supplied by oculomotor nerve. Now, why is that important? Because if I have a lesion in my eye, I need to understand what happens. And I need to know, based on my clinical examination for that patient, I will understand the problem of that patient is in which eye. And the nerve problem is which nerve, okay? So we might have a nerve problem and we want to selectively test which nerve is affected, which is what we're gonna do now. Or there might be a problem with the muscles, and this is another story, muscles themselves. And we talked about some of them on how to isolate them. Now, in the primary position of that patient, he will come to you to the clinic looking like that, the midline features, okay? If that patient comes to you and his eye is locked in abduction, whether you tell him look to the right, it's in abduction. Look to the left, it's in abduction. Don't look anywhere, it's in abduction. It means, you guys, that the lateral rectus muscle is very good and it's dominating over everything else. Someone will come and tell me, okay, fine, but SO4 is also not supplied by oculomotor nerve. Why it's not affected? Why it's not giving us any sign? Because you guys remember, the superior oblique is doing a function and the recti are doing same functions, so they can compensate for that problem. It's not selectively important for that. But lateral rectus, no one can help in the main function of the lateral rectus. It's abduction, and it's a very good nerve, and the nerve is working in this case. So it is dominating over everything in the primary position, in looking to the right, in looking to the left. So if you have a trochlear nerve problem that supplies everyone except superior oblique and lateral rectus, the lateral rectus will dominate. Superior oblique has nothing to do because it cannot dominate. We have opposing muscles to the superior oblique, and they are all there in that muscle. But lateral rectus, when that nerve is normal, so lateral rectus will dominate over all positions of the affected eye, which is the right eye. So in the right nerve palsy, how to remember it in the exam, it's all about the domination of the lateral rectus over all other muscles that are paralyzed. Now, what will happen in the superior oblique, guys? In the superior oblique, guys, remember that the superior oblique is the main muscle that causes intorsion. It's the main muscle that causes intorsion with depression. It's the one that brings your eye down here and to the center. So if you have a patient with a problem in superior oblique muscle, his eye will be outwards and upwards because this muscle mainly is doing intorsion and slight depression, because we know recti are also doing depression. Okay, so that patient will come to you with an outward and upward. And I remember that I told you guys, remember, the main problem you will have is with the intorsion, because he is the main player. Intorsion, the obliques muscle are the main player, and this is a separate nerve. If I have a problem with this nerve, I will lose intorsion. Now, what if I told that patient to look to the right side? Okay, fine, he can look to the right because I don't need superior oblique. This is outward and this is down here. So superior oblique, we don't need it to bring the intorsion and depression medially. So if that patient looks to the right, he will be fine. If you ask him to look to the left, he can look to the left, but he cannot make the intorsion depression kind of combination. All right? So in normal cases, he will have his eye in upward laterally because superior oblique is not doing intorsion depression. And when you ask him to move his eyeball into left side, the right eye is affected. If you ask him to bring it to the left side in adduction position, the eye will be going outward. It's not going to be in intorsion down position. Okay? And remember that when I told you previously, when we want to selectively test the obliques, we have to bring the eye into the adduction position. So in add, I can know that there is a problem with the superior oblique. Okay, so the superior oblique, if you ask the patient to look at the other side, abduction, in abduction, you don't have any problem. In normal position, It's outward and up. It cannot do the intrusion depression kind of combination. And if you ask him to bring it medially, okay, here we can selectively understand that there is a problem with the superior oblique because this is an adduction position, okay? So it will be going above, not in intrusion, and you will have double vision, all right? Now let's come to the last one. So here it's all about the loss of intrusion, guys. So how to remember that in exam? It's all about the intrusion, loss of intrusion. Now what happens to lateral rectus? Okay, fine. When I have a patient coming to me, he will lose the ability to have his affected eye into abduction because lateral rectus is the main one that causes abduction. So it will be, if we have if we have a plane here, an axis, you will find that the eyeball is turning medially because the chief lateral muscle, which is doing abduction, is not working. Okay, so it's not working. It's opposite to this. Here it's dominating. Here it's not working. So no way you can bring your eye into abduction because lateral rectus is the main one that does abduction. So in the normal patient, in the normal circumstances, the patient is entering your clinic, you will find that his eyeball is medially rotated without anything. And then you tell him, can you look to the right? He will look with this eye, but this eye cannot come there because the lateral rectus is not doing abduction. I have a problem with the right eye. Okay, fine, can you look to the left? The patient will look to the left. Yes, he can, because lateral rectus has no role in adduction. And this lateral rectus is already working, it's fine. So lateral rectus, you will lose the ability to do abduction only when it's needed. So if I ask this patient to look at that side, okay, it's not needed here. So he will look to us normal, okay? So as a recap, so lateral rectus is all about the paralysis of lateral rectus and loss of abduction when it's needed. So remember, if you have a problem with oculomotor nerve, the right eye will be locked with lateral rectus in all positions and all movements. If you have a problem with the superior oblique, your eye will be in normal circumstances losing intrusion, so it will go up and lateral. And when you ask the patient to look medially, because this is selective for oblique muscle, it cannot come down here. So this is superior oblique, okay? Loss of intrusion and depression because of superior oblique. However, here, superior oblique is not needed. So if you ask him to look to the right, superior oblique is not needed, he will look to us normal. Lateral rectus, it's the opposite. If we ask him to look medially, lateral rectus is not needed, so he will look to us normal. And you will have a problem if he comes to the clinic. Yes, he's losing the abduction because no lateral rectus. And here, he will lose the abduction also because there is no lateral rectus when you ask him to look to the right. Okay, so if you have a problem with oculomotor, the problem will show domination of lateral rectus in all positions. If you have a problem with superior oblique muscle, fourth cranial nerve, nothing will happen when you ask him to look to the right because superior oblique is not needed. But you will have a problem with normal position, and when you bring it to adduction, you are selective about superior oblique and inferior oblique. And superior oblique, when it has a problem, it means you cannot do depression. And if you ask the patient, if you are having a patient with the lateral rectus problem, abducent nerve palsy, nothing will happen when you don't need the lateral rectus, because for the diseased eye, you don't need abduction. Here you are already in adduction, so it's gonna be normal. And the problem will happen in the other two motions. Okay, guys? I hope you guys grasp that concept. You can listen to it one more time and you will find it very easy to understand that. All right? Now coming to the blood supply from the ophthalmic artery, because you guys know that we have ophthalmic artery that comes from internal carotid. It will give you so many important branches. Some of them are short and long ciliary that we go to supply the eyeball itself. And then you will have muscles near to your nose, which what we call the anterior and posterior ethmoidal arteries. And then you have muscle that comes to the trochlea here above. This is here. We call them supratrochlear and supraorbital. So you have supratrochlear, supraorbital coming to the front of the head. And we have people in the nose side, anterior posterior ethmoidal and dorsal nasal also from there. So you have people here, you have people going there, you have people to the eyeball itself, short and long ciliary. And then you have the central retinal and the lacrimal. They will go to the retina and the lacrimal gland. Okay, so if you just remember them by groups, it's going to be very much easy to know. Again, that the ophthalmic artery will give you anterior posterior ethmoidal, dorsal nasal, people to the nose. You have people coming to the forehead, supratrochlear, supraorbital. You have people going to the eyeball, short and long ciliary, and one going to the retina, the retinal, central retinal, and one going to the lacrimal, which is the lacrimal artery. For the the superior ophthalmic vein and inferior, the only thing I want you guys to know is that the superior ophthalmic, guys, it has communication with the cavernous sinus. It drains into the cavernous sinus. And the inferior ethmoidal, it has, ophthalmic, it has communication with the pterygoid plexus of vein, which is very important for the spread of infection. If you have infection in the eyeball, it can easily get into your cranial cavity, because you know the cavernous sinus are on either sides of your, remember the pituitary gland and the sella turcica and that stuff in the sphenoid bone. So superior ophthalmic has communication and it drains into this, and the inferior drains into the pterygoid plexus, and that also drains from the facial vein, so that and even the nose. So that's why infection from the nose can spread to the eye, can spread to the cranial cavity, can spread to parts of your face, and this is how dangerous this place is. So remember the communication between the superior ophthalmic cavernous sinus and inferior ophthalmic and pterygoid plexus of veins, which is also communicating with facial veins, right? Now coming to the nerves, in a practical note, the nerves that we have in the eye, guys, remember that they are either people coming from the trigeminal, because you know that the trigeminal is a sensory nerve for the face, okay? Or they will be people that supply your extraocular muscles. We already talked about the cranial nerves that supply the extraocular muscle. And now I want to talk about the nerves that are coming. Remember the trigeminal, we had the ophthalmic, we have the maxillary and mandibular. Ophthalmic is what concerns me here because this is the eye. So this is a sensory nerve. So if I have a trigeminal nerve that has the ophthalmic and it gives maxillary and mandibular, that is what concerns me, and I have a practical exam and I need to try to understand what are the nerves. I have three major nerves. One in the center, which is frontal. It goes all the way to the frontal bone to give supratrochlear, supraorbital nerves, and it exits from here to give you sensation in the forehead. And then you have medially a nerve called nasociliary, which is deep nerve. This is not the nerve. This is the nerve that supplies the superior oblique. Remember that we have the superior oblique here on top of medial rectus. The nerve that supplies it is the trochlear. It runs on the superior margin of the superior oblique. But the other nerve that is medial from the ophthalmic, ophthalmic division of trigeminal, is the nasociliary. It's going to be deep here. You cannot see it unless you dissect. And you have a nerve laterally called lacrimal nerve that will go and supply lacrimal gland sensory innervation. Again, it's sensory innervation. It's not a secretory motor innervation. It's not responsible for asking your gland to give you tears, because this is not parasympathetic innervation. This is trigeminal nerve, cranial nerve number 5. Okay? So these are sensory innervations. So in the front, you have the frontal nerve, medially nasociliary, and we call it nasociliary because it gives nasal stuff and ciliary stuff. And then laterally, the lacrimal nerve. These are sensory nerves. And this is what you can see in a practical note. And if you look at the muscles, remember that I told you the superior rectus is on top, covered by levator palpebrae superioris. So you have the medial rectus medially covered by superior oblique, and the lateral rectus doesn't have anyone with her. All right? So these are the branches of oculomotor nerve. This is moving on to the nerves that supply the extraocular muscles. Previously, we talked about the sensory nerves from the trigeminal, which is the ophthalmic divisions. And here we're talking about the nerves that supply the extraocular muscles. which is the oculomotor nerve. And in that case, oculomotor will have parasympathetic fibers for the ciliary ganglia. And we talked about the parasympathetic of ciliary ganglia in a different video. It's not here. And this is how the oculomotor nerve will give you with a superior branch, nerves to people on top and medially, and the inferior branch will give you to the inferior people. All right? Now, this is a practical note. Like I said, we have, when we look at the practical exam, we have muscles in the center, medially and laterally. Recti muscles are everywhere. So in the middle, you have the superior rectus. Medially, you have medial rectus. Laterally, you have lateral rectus. And so forget about the recti. They are deep there and everywhere. Now, I want you to remember that when you have in the practical exam and you want to look for something, and that thing is medially, this is going to be the one muscle, one nerve. Actually, there are two nerves. Okay, you can see, but it's not in all cadavers you can see them, but fine, we can say one muscle, one nerve, because we are talking about the branches of ophthalmic nerve now. Okay, trigeminal, ophthalmic nerve. Remember that I told you frontal is here, lacrimal is lateral, nasociliary is medial. So this is what I mean by one muscle, one nerve, one muscle, one nerve, one structure, one nerve. And that structure is the lacrimal gland, the lacrimal nerve going to supply it sensory. Medially, you have the frontal nerve and the levator palpebrae superioris. Medially, you have your superior oblique and the nasociliary nerve. These are branches of ophthalmic and the muscles that we talked about them and that extra structure. However, yes, you have another nerve here, which is the muscle, the nerve that supplies the superior oblique, which is SO4. You guys all know it. This is trochlear nerve. It comes all the way, very thin nerve, and it runs on top of the superior oblique. Okay, so this is something not related to the note I have here. This is what's related to the note is the nerves that comes out of ophthalmic nerve. Okay, so as I said, recti are everywhere, superior rectus, lateral rectus, medial rectus. We will look for them deeply. And then on top, we have the levator palpebrae superioris, topped by the frontal nerve, division of ophthalmic. You have the lacrimal gland supplied by lacrimal nerve, division of ophthalmic. And superior oblique, deep to it, is the nasociliary nerve, which is also not there in most of cadavers. And this is how you guys in practical, you can see that here the frontal nerve is in the center, okay? And you have the lacrimal nerve that goes to the lacrimal gland laterally. And you have the nasociliary deep inside. The muscle on top of the levator palpebrae superioris, deep to it, you have the superior rectus, which I cannot see here because I can see the optic nerve only. I cannot see the superior oblique, but it should be down to this. And medially, you have the superior oblique, all right? And the superior oblique, if you can catch a nerve that runs on top of it, it's going to be the trochlear. And deep is the medial rectus here. This is medially, this is the superior oblique, deep is the superior, I cannot see it here. And remember when I told you that laterally is the lateral rectus only. Forget about the lacrimal gland now. Laterally, you have the lateral rectus only. And the nerve that runs deep to the lateral rectus, deep to it, it's going to be the nerve that supplies it. It's going to supply, which is LR6, okay, the abducent nerve. Okay, so when we said that one muscle, one nerve, one muscle, one nerve, one structure, one nerve, we are talking about branches of ophthalmic nerve supplying structures medially in the center and laterally. But if we remove people outside, we can see people on side, okay, which are the nerves that supply those muscles themselves. So if I know that this is lateral rectus, then I know that the nerve that supplies it is the abducent, okay? If I know that this is superior oblique muscle, then the nerve that goes to it is the trochlear, okay? And we already talked about the ophthalmic divisions. One also nice one here, if you try to remove the lateral rectus, you can see the ciliary ganglia, guys. And remember that was the lacrimal gland laterally, and the nerve that supplies it was the lacrimal nerve. All right, guys, so this is the ciliary ganglia. You need to remove, and it's very small spot. You cannot, it's very difficult to see it in many cadavers in real life. You remove the lateral rectus, you'll be able to see the ciliary ganglia. Now, what about the structure of the eyeball? So generally, your